It's nice and pink.
Screen
Sam is in
The
a
full
pink
screen
also.
nahi hua. Make it full screen.
Yeah. Is it full now?
Right.
Yes, ma'am. So,
Yeah.
on behalf of Chennai Menopause Society, I welcome all the faculty and logged in delegates to this very important webinar, the series 3 of its kind. And it's going to be on breast cancer awareness, taking into account October being considered as a Pinktober, and it is the third of its kind. And we have very eminent faculty who is going to give an overall idea about how to approach a breast cancer, how to diagnose in its early stages, and how to treat once we diagnose breast cancer. And we'll start the session. Tamil Thai Virus.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் மதனமென திகழ்வரத கண்டமிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு திரை நுதலும் தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே உன் சீரிழமை திறம்பியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Happy to introduce our beloved President, Chennai Menopause Society, Dr. T.K. Shanti Gunasingh ma'am, to give the welcome address. And as we lighted the lamp to dispel the darkness surrounding breast health, we request Shanti madam to invite the speakers for the first session. And first introduce the, Let me ask Shanti madam to give the welcome address to the delegates gathered here.
Yeah. Good evening, one and all. It is indeed a pleasure to have this conference on breast health, which is of importance to us, especially since it is the month of menopause and month of osteoporosis, and as Dr. Dhanlakshmi said, Pinktober too. So we lay a lot of stress on breast cancer, which affects which is the commonest cancer in our women. So here to have that, I mean, this is our third webinar, and we are indeed very happy to have Dr. Anita Shah from Surat with us. So she is our Vice President of IMS, and I have great pleasure in welcoming her. And we are really very happy that she's able to join us, who has done, has a very long stint as Ujishian in Surat, conducted lot of conferences, and earlier also IMS Con, she conducted successfully in Surat. And now again, she's the vibrant president of IMS. We welcome her here, and we are really happy that she's able to join. And she will also release our Model 3, our e-newsletter. We are very happy to have as the guest of honor our own Dr. Jayashree Srinivasan, our past president of Oxy and present HOD of OG Savita Medical College. So it is really a pleasure to have her here. And then we have lot of eminent faculties to speak on breast health. We have great pleasure in inviting Dr. Selvi Radhakrishna. Then we have the others like Dr. Samundiswari and a very interesting trilogue which will be projected by Dr. Bhavana, Dr. Sandhya, and that will be really very interesting. And we have our eminent chairpersons, Dr. Kundavi, Dr. Meen Lochini, Dr. Veni, who are all active Oxyans. So, and of course, our delegates who are going to relish this academic feast and then render invaluable care to our women. I welcome one and all. Now I welcome Dr. Anita Shah to, I think we have to go in for our midlife prayer. So I welcome Dr. Mala Raj to render the midlife prayer.
Dr. Mala Raj was a founder secretary of IAG Tamil Nadu chapter and managing council member of IAG. She is a very active member of Oxy as a joint treasurer. She is a past secretary of IMS during 2010-2012, and I welcome her to render the midlife prayer.
Yeah, thank you, ma'am. Midlife prayer. We pray to God to give us grace to accept the midlife physical changes and gently renew our strength. Guide our heart, our mind, and body to navigate the way and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond moments of their life, and also for those in doctor's office or who are in bed asking for healing touch. On this day, may all the midlife, menopausal women have the gift of joy, hope, and good health. Thank you, God, for the promise of hope you hold out to all midlife and menopausal women and inspire us to give this gift of hope to others.
Thanks, Mala.
Thank you, ma'am.
And I request our chief guest, Dr. Anita Shah, to give a valuable address to this gathering.
Yeah. Dear Dr. Santhi, Madam, Dr. Dhanlakshmi, and the whole team of Chennai Menopause Society and Chennai OBGY Society. It's my pride privilege to be over here to address this very, very important webinar. We all know very well that October month we are celebrating as month of menopause and month of osteoporosis. And we just want to spread a lot many awareness regarding menopausal issues as well as cancer awareness. And the talk webinar arranged today is really, really very important because we all know that nowadays breast cancer has become #1 all over the world as well as in India also. We can say that 25.8 per 1 lakh women and mortality is 12.7 per 1 lakh women. And as we know that most of the time people think that cancer means cancel and they just want to avoid their regular checkup by the gynecologist. So from this platform, it's my earnest request to all the healthcare providers that encourage their patients to get themselves checked every year, just like they celebrate their birthday and anniversary. So all the faculties and moderators and panelists are very, very learned members. And I'm sure that we will definitely enjoy a delicious academic feast by this webinar and we'll have a lot many carry-home messages. Thanks.
Thank you, ma'am.
Dana, we can ask Madam to release
Yes,
the
ma'am. Yes, ma'am.
medal.
Yes, ma'am. You can ask, madam.
Yeah.
Madam Anita, ma'am, can you say we are releasing medal 3 and I'll open it, madam?
Okay. Yeah. I'm so happy that I'm giving this opportunity to release the medal 3 made by Chennai Menopause Society.
It is a flip book containing the events that we have conducted after the last webinar. The events
Okay.
between the second and the third webinar are collected together as a small flip book. So it not only brings out the academic part of it, contributed two chapters that contributed by Dr. Samdeshwari and Dr. Selvi Radhakrishna, and we also have small tidbits like brain gym and all that. So once you, we'll be sharing this link to all of you when the webinar is over, and you can go through it. Thank you so much, ma'am, for releasing this book. And I request Shanti ma'am to welcome our guest of honor. Jayashree madam, are you there, ma'am?
Madam is there?
I am not sure, madam. Sahiti, is Jayashree madam logged in?
They are logged in.
Yeah.
Okay.
Meenlochni madam is logged in.
Yeah.
Okay. I have great pleasure in inviting Dr. Jayashree Srinivasan, one of us, and a very proud Auxian who was the best outgoing student in Chengalpet Medical College and received the Sir Ale Modria Traveling Fellowship, CS Don Best Paper Award. She retired as Director in Charge IOG, past President Oxy 2013, when I was the joint secretary. So I was really very happy to work with her as joint secretary. And she published a lot of papers in national and international journals, given a lot of orations, and felicitated by the Oncology Committee of Foxy. And most important, she is an excellent teacher. So I have great pleasure in inviting Dr. Jayashree Srinivasan as a guest of honor.
Avi, the one who's named as Jayashree Srinivasan is not Jayashree Srinivasan, Sahiti. She's Dr. Meenlochni.
Okay, ma'am. Okay.
So just find out whether she's come. Otherwise, we'll get her address. Maybe whenever she joins, we'll ask her to address the gathering. Let me introduce chairperson. She was our very humble Oxy president, and she had the senior consultant OBGYN and Apollo Hospital Chennai and MK Nursing Home, Dr. C. Veni, and she was a former medical superintendent of Rajiv Gandhi Government General Hospital Chennai, former controller of examination, and she was the first one to introduce online delivery of question papers in Tamil Nadu. She was our beloved president of Oxy in 2017. She was undergraduate and postgraduate teacher for almost 35 years and also an examiner for in various universities. We welcome you, ma'am. And then we welcome Dr. Meenlochni. Ma'am, you can put on your video, ma'am. She was done an MBBS from Madurai Medical College and MD and DJO from Madras Medical College. And she was secretary for Dr. Jay Srinivasan's during Jay Srinivasan period. And they both of them together delivered so many good programs. And she was a former state trainer for government family welfare programs, UG and PG teacher and examiner. Actually, we miss her a lot during our Chennai programs as she's settled in Madurai. So I just pulled her into this webinar. At least the webinar, we are able to see you, ma'am. And
Thank you, Dana.
the next chairperson that we are going to have is none other than Dr. Kundavi. She is very active Auxilian. She's a secretary for Dr. Jairani Kamraj, and she is, in spite of her busy schedule, she finds time to do all the activities of the society, and she has agreed to be our chairperson for this first session. I request the chairpersons to take over the session and introduce the speakers for the session.
Thank you, Dana ma'am. It's a pleasure and honor to introduce Dr. Selvi Radhakrishna, who's a leading consultant oncoplastic surgeon of Chennai practicing breast center. She finished her MBBS in 1988 from Madras Medical College, and she's got a comprehensive training at Chennai and at UK and with National Board, and has taken up an FRCS at Edinburgh and postgraduate diploma in clinical oncology at Birmingham, UK. She set up a state-of-art breast cancers in Chennai called Chennai Breast Center. She has authored a book called All About Breast Cancer for Patients in Tamil and English. She conducts regular skill course in breast imaging and interventions, has been a faculty for operative workshops and conferences across the country. Over to you, Dr. Selvi, to talk about the recent advances in management of breast disease.
Thank you. Thank you so much.
Selvi, I'll stop sharing. You can.
Yeah, I'll share my
share it.
screen.
Yeah.
Okay, there you go. Good evening.
Yeah, we are able to see you.
Let's make it slideshow. 1 second. In the beginning. Yeah, see my screen?
Yes, very much.
Thank you.
Yes, ma'am.
So just to briefly give you a perspective of the key developments in breast cancer management, I've got a set of key figures and the timeline. So this is what who everybody knows, William Halsted. So Halsted's modified radical mastectomy was the procedure practiced for over 100 years until the early 20th century. And then the procedure, the Halsted's concept was everything was local. It all developed in the breast, and I mean the concept of systemic spread and death due to other organs failing was not so well understood then. And so therefore he did very, very radical surgeries that included removal of the breast, the pec major, the minor muscle, clearing level 3 lymph nodes, removal of even supraclavicular lymph nodes. So supra-radical mastectomy. So this left with a very morbid consequences, like patients, most of them developed massive lymphedema and a very deformed chest wall and lived a very poor quality of life. And then came Bernard Fisher. So Bernard Fisher's picture is not here in this series of pictures that I put here, but interestingly, with the World War II in the 40s, they used nitrogen mustard in the World War as toxic gas as a part of warfare techniques, and then they found that it had some cytotoxic. The cytotoxic thing worked for cancer as well, and then systemic therapy for cancer started developing post 1940s, and closer to the 70s. So the breast cancer chemotherapy and the understanding of the fact that breast cancer is not just local disease, that it is a systemic disease, and that it could be a systemic disease at the start itself. That came about in the 70s. And then so therefore, we started de-escalating the amount of surgery that we did for breast cancer. So then out went radical mastectomy, and then we modified it a little and called it modified radical mastectomy, which is still today practiced in some way or the other. So the modified radical mastectomy means that we try and preserve the pectoralis major and minor muscle, but it includes removal of all the 3 levels of lymph nodes. So this was widely practiced, and then a surgeon called Pegetz. We're all aware of what other achievements Pegetz Paget's, Paget's disease of the bone, Paget's disease of the nipple areola complex. He also developed a surgical technique called, sorry, not Paget, so Patey. So Patey's mastectomy. So this ruled the roost, where the pectoral minor muscle was divided and removed along with the mastectomy specimen. And this gave good access to the axilla. And then we found that dividing that also was unnecessary. We could easily retract the pec minor muscle. And then came the other procedures, the Auchincloss modification of Patey's mastectomy. So those were the techniques that were practiced in the 60s and 70s, where the medical oncologists were also giving a bit more of chemotherapy after surgery. So, and then came the NSABP trials. So Bernard Fisher, he developed this set of clinical trials called the National Surgical Adjuvant Breast and Bowel Project. So both colorectal cancers and breast cancers, they set up a series of tests, clinical trials. And with those clinical trials, one of the first clinical trial was to compare axillary clearance versus no axillary clearance, and then quadrantectomy versus mastectomy. And so then in the 60s and 70s, Veronesi, he passed away 4 or 5 years ago. So Veronesi is from Italy, and he developed this procedure called quadrantectomy, where he said, okay, let me remove the quadrant where the cancer is found. And with quadrantectomy, then they preserved the breast, and then they looked at the breast conservation surgery trials. About 6 or 7 trials came up in the 80s and 90s, and it slowly started becoming the standard of care. So with the, obviously only surgery cannot be the advancement. So with in the 1960s and 70s, mammography became a part of armamentarium for diagnostics. So we had better imaging facilities, and with that we understood the local extent and the involvement in the breast and the amount of tissue that we could remove. And then we have can we mute so that
voice muted?
Sorry, slides are not moving perhaps.
Can you hear me?
Yeah, but your slides are not moving.
I'm still in the same slide.
Okay.
It shows the timeline about what each person did. So it gives a comprehensive understanding of what went through in the history of development of management of breast cancer. So then the Fisher's theory with chemotherapy came about, so then we got to understand that systemic management is equally important as well as surgery. And then the targeted therapy, the understanding of immunohistochemistry, understanding ER, understanding PR, understanding HER2. So HER2 is the overexpression of HER2 was thought to be a bad prognostic sign. With the development of anti-HER2 therapy by a gentleman called Dennis Lehman, it revolutionized breast cancer management, particularly HER2 positive breast cancer management. Today, HER2 positivity, because of the availability of multiple targeted treatments against HER2 receptor, it's now, it actually downstages on the TNM classification irrespective of the size or the node positivity. And then came about parallelly, there was a lot of research going on into genetics of breast cancer. In the 1990s, Mary Claire King, she was the one who discovered the BRCA gene, BRCA1 gene, and then came about the BRCA2 gene. With that, we understood the connection between breast cancer and ovarian cancer, and with it came some developments in the management as well. So in the year 2000, we de-escalated treatment as far as mastectomy is concerned. We started doing more and more breast conserving procedures. But what we continued to do was axillary clearance. And with axillary clearance, we all know there is a risk of lymphedema. So and we wanted to look at the need for de-escalating axillary treatment also. Many times we'll remove all the nodes and then we realize that there is all the nodes are free of cancer, and that removing all the nodes led to lymphedema. So therefore, a procedure called sentinel lymph node biopsy was developed, and now it has become the standard of care for clinically and radiologically node negative early breast cancer. So this after the millennium, in the early part of this century, a concept of combining cosmetic procedure along with breast conservation procedure. So a new branch of breast surgery called oncoplastic surgery emerged, which is added to the surgeon's armamentarium in making quality of life an important part of a breast cancer patient. So the recognition of breast as a specialty came about in the 1990s with the understanding that overall survival increases with specialization of doctors, particularly in the diagnosis and treatment of breast cancer. So there was one big study in 1996 from BMJ, which looked at 3,786 patients, which showed survival outcome of care by specialist surgeons in breast cancer was definitely better than others doing the breast cancer treatment. So in the new millennium, specialist breast centers developed, and it was pioneered mainly in the UK, Europe, and then America was a little late to take up on this. And we were very much behind, but in the last 10 years in our country as well, breast surgery and breast as a specialty is picked up, and I get queries, at least one mail a week from young aspirants, particularly women, wanting to train further in breast cancer, which is very, very positive and heartening. So the gold standard is multidisciplinary approach. So the radiologist, the surgeon, the pathologist, the medical oncologist, radiation oncologist, palliative care physician, all of us put our head together to give the best possible outcome. All disciplines evolved in the meanwhile, in the last 100 years, along with breast surgery. So from a very primitive analog mammography machine, CR machines, full field digital mammography, and now the 3D mammography, breast MRI with 1.5, 3 Tesla machines, image guided biopsies. So ultrasound guided biopsy, stereo guided biopsy, MRI guided biopsy, all of these techniques evolved, and now with very slick procedures done as outpatient procedures, all these are possible now. And breast pathology also developed along with gross pathology, which is still indispensable. Immunohistochemistry, understanding the molecular biology, molecular classification, and understanding the germline and somatic mutations. So, and gave us a better workup towards genetic mutations prevent cancer. And now we have it all digital now. Digital pathology labs are in, and so slide sharing and getting second opinions, archiving all of these things have become very, very good and easy. And then medical oncology cannot lag behind. So third generation chemotherapy that includes taxanes, targeted treatments, and personalized care. So you take out a bit of tissue, take out a bit of blood, liquid biopsies, get some understanding about gene mutations, and personalize, see whether they're resistant to the therapies or they're sensitive to therapies, and accordingly plan therapy. So this has become the future now, and a lot of work is going on in this direction. And then radiation oncology, from the very primitive cobalt machines, which did indeed cure a lot of breast cancer patients, but ended up leaving the conserved breast very firm and hard and very not very nice looking breasts. From that, we moved on to intensity modulated radiotherapy, image guided radiotherapy, partial breast radiation, and then the duration. So we all know that radiation time, machine time is very precious. We need to treat more patients. So therefore, from the prolonged 25-day session therapy, it's now come down to 15 hyperfractionation. So we finished radiotherapy within 15 sessions. And now with COVID and some new evidence available, a lot of early breast cancer, node negative, good risk breast cancers, we just give 5 days of radiotherapy, which is made acceptable and easy for patients to undergo radiotherapy. Cost has come down, so optimal use of radiotherapy facilities are possible. So this so much so that breast cancer was a model organ cancer for other cancers to develop. This was a template based on which other cancers also, the models for other cancers also developed. So Hiriam Cody, one of the well-known breast surgeons in the USA, in his presidential address in one of the big meetings, he gave this statement where, the biology of the cancer is a king and selection is the queen. And technical procedures like what we do are only the prince and princesses. And occasionally we try to usurp the throne, which is the biology. And we almost always fail. So we have to respect cancer biology. A lot of it is evolving. And hopefully before the end of my career or my lifetime, we will see more progress in that area, which will get rid of the need for surgeons. So as far as surgery is concerned, right from radical mastectomy to what we do now, de-escalation is the theme. So we don't want to do too much. We want to do less, which is adequate. So with breast conservation therapy, oncoplastic breast surgery, sentinel lymph node biopsy, quality of life and survivorship, because with all the targeted therapies, with all the chemotherapies, with all the advances in radiotherapy and hormone therapy, people live long now. And so quality of life and survivorship becomes very important. So therefore, all these surgical techniques have advancements in the surgical technique have contributed to the quality of life. So as we all know, when we do breast conservation surgery, meaning take out only the lump with the margin, with a clear margin, leave behind the rest of the breast tissue, it has to be combined with radiotherapy. Breast conservation surgery without radiotherapy carries a high risk of local recurrence. So therefore, this should be combined with radiotherapy. The equivalence of breast conservation surgery was well established in the 80s and 90s. And we now have studies which show that in stage 1 and 2 breast cancers, breast conservation surgery is in fact got better outcomes, longer overall survival rates when compared to mastectomy. So it's not just equivalence to mastectomy, it is better than mastectomy. And that is, several studies have gone to show that. And the long-term results are good. But in the early years, we removed too much. We had poor radiotherapy techniques. So the cosmetic outcomes were not great. So therefore, poor quality of life. You leave behind a very shriveled looking breast, which does not look very good. So now with the understanding, we did more and more MRI, we saw the blood vessels going into the breast tissue. We saw it in different planes. We saw it in axial view. We saw it in lateral view. We saw it in coronal view. So we understood the blood supply and therefore reshaping the breast with plastic surgeons and surgery options resulted in an emerging specialty called breast oncoplastic surgeons. So we said that earlier. So these are some of the conserved pictures. So you see how full and nice the untreated breast. Here after surgery, in the upper inner quadrant, there is a loss of volume and the nipple is pulled to one side and you can see that there is a loss of volume here. She's okay with it, but then we could do better. Here you see removal of the tumor in the 6 o'clock position. So here, there is a parrot, what we call as a parrot beak deformity. So this like there is a depression here, and very asymmetric looking breast. So these are all, now there are different options available to give a better looking breast. So oncoplastic surgery involves integration of plastic surgical techniques. So we achieve optimal cancer control and have a better looking breast. So any loss of over 10% of breast tissue volume will need oncoplastic surgery. Anything less than 10% may not affect cosmesis and you can just stitch it up together, not involving big procedures. But anything more than that, then we may need some cosmetic procedure along with the breast lumpectomy. So advantages that we have wide excision, we have good aesthetic outcomes, and it avoids mastectomy in selected patients. and less surgery, psychologically definitely better. And it's definitely, you know, mastectomy followed by reconstruction is definitely a much bigger procedure with a lot more morbidity. So in that sense, it is definitely less of side effects. And post oncoplastic surgery, particularly in large breasts, when you do reduction and operate, it tolerates radiotherapy better. So there's a whole range of techniques available. I won't go into detail depending on the quadrant, you know, upper quadrant or lower quadrant, or tumors located anywhere. There's a whole range of procedures available. So we have broadly two concepts where we just displace the tissue in the breast itself, mobilize a little here and there, and use the breast itself, displace the breast to actually put it together, reshape it better, and close the cavity. So these such simple glandular rearrangement techniques, what we call as round block technique, a Batwin technique, crescent excisions, Grissotti flaps, using parallelogram incisions to remove the tumor so you don't have asymmetry in the breast, Z-plasties, matrix rotation, reduction excisions, all of these come under the heading where we displace the breast tissue, do not borrow tissue from anywhere else, and within the breast tissue, we reshape the breast. So some of these procedures may require a opposite breast procedure to symmetrize. So particularly when you do a large breast, when you reduce the breast as a part of removing the tumor, then you cannot leave behind one breast that is small and one breast to its original size. That will be gross asymmetry. So you do a contralateral reduction to match the treated breast. So all of these procedures may also be required. And then we have what we call as volume replacement. So we bring in tissue from the back, from the either the latissimus dorsi muscle or the fat by the side of the breast, or below there is a pad of fat just under the breast in the inframammary crease. So what we call as ICAP flap. It is anterior intercostal artery perforator based flaps, or the lateral intercostal artery perforator based flaps. And then you have the TDAP and TEF flaps. There are a lot of different flaps which use skin, which use without skin. So many such flaps are possible. And then the whole breast can be reconstructed with pedicled flap like latissimus dorsi, extended latissimus dorsi flap. Free flaps like DIAP flap, deep inferior epigastric artery perforator flap, the tuck flaps using the gracilis muscle. So many such options are available. So the oncoplastic surgery, or what we call as OPS, depends on the size of the breast, the tumor size, location of the tumor, the type of the breast density is important. So we may choose a different procedure for a very fatty breast tissue. On the other hand, we may choose an alternate procedure for a very dense breast tissue. So type of the breast is also important. Ptosis, the droop of the breast. We know with breastfeeding, there is a droop that is natural. With weight gain and weight loss, there is a droop that is natural even in non-lactating, in patients who have not lactated. But this ptosis is also important in factoring in the type of oncoplastic procedure that we choose for the breast conservation procedure. So here you see some breast conservation procedures where you don't see much difference at all in the appearance of the breast. So this is the normal breast. This is the treated breast. You see the tinge of pigmentation that you see post radiotherapy. This is many years after radiotherapy. You can see the in comparison, this is slightly more pigmented. That is the treated side. Here again, this is the treated side. And this breast, you see the circumareolar incisions. And you see between this side and this side, this is the treated breast. And here again, this is a treated breast. And this side is a treated breast. You can see that little mark post-pigmentation, post-radiotherapy. You see here again, an incision. This is the sentinel lymph node biopsy incision. Again, very reasonable looking breast. So here we borrow tissue from behind. This is partial breast reconstruction where I used an LD flap. So this is an incision in the back where I have to use to harvest the LD muscle with the fat, and that is filled into the breast, and that actually gives the symmetry. So this is a frontal view where you see that the breast is almost similar to the other breast. And here she had a D-cup breast where there is ptosis and the tumor is in the inner quadrant, and she is in her young lady, and we didn't want to do, we obviously didn't wanted to avoid a mastectomy. So what we did was lifted and reduced the breast a little bit. So this tumor came off as a part of reduction. And this was the post-op picture where, lifted up breast with a more manageable size. And here again, you see, this is a very large, in an obese patient, very large pendulous breast with grade 3 ptosis. So this is the droop that she had. No, this is a tumor. And if we end up doing a wide local excision here for this patient, radiating this breast is a nightmare. The radiation oncologist will not be able to achieve dose homogeneity to deliver. She will have a lot of radiation reaction. And if you do a mastectomy, she'll have a very lopsided breast, and she'll have a lot of issues in trying to get symmetry with the processes, back pain. She might even get a kind of scoliosis because of weight on one side and nothing on the other side. So here we do a reduction procedure, remove the tumor as part of the reduction, and this is the appearance you get, a very cosmetically acceptable looking breast. Here, we did a skin sparing mastectomy. So the skin of the breast is preserved. Mastectomy is done through this central hole where the nipple areola is removed. And we use latissimus dorsi muscle to fill this space. And a skin paddle from the back is used to create the nipple areola complex. This can be tattooed, and we can do a nipple reconstruction. And tattoo can be done, which will give a normal looking breast. So this is her a few years after the procedure. Obviously, many people don't follow up with the procedures. She was not too keen to do further tattooing and whatever, but you can see that, in the bra, it fits well, and she's happy with the reconstruction. So then there are, the 6 o'clock position, when you remove, I showed you there earlier, where it results in a parrot beak deformity if you don't replace the volume. Here we've replaced it with what we call as an ICAP flap based on the anterior. So the anterior intercostal artery perforator. So we get the anterior intercostal perforators coming in the midline from here. So along this entire length, you get that perforators coming from every rib space. So we use one such perforator in the inframammary crease and use this pad of fat. All of us have this pad of fat here. So this is the cavity excision here. And this is the pad of fat that we've harvested. Remove the skin on top there and flip that. So this somewhere here is the perforator. So we don't go and cut off the perforator. You should be careful not to cut it off. And just flip that wing like this, fold it, and then put it inside the cavity and fold the skin over and suture this. So it fills that volume and gives a good shape. And these are perforator flaps. Similarly, from the lateral aspect of the breast, we can bring in fat that we call as lateral intercostal artery perforator flap or LICAP flap, which will fill in defects in the lateral aspect of the breast. So when you do an oncoplastic surgery, obviously the pathologist needs to be oriented properly. We leave behind the clips, the titanium clips in the tumor bed and the pillars of the breast tissue for the radiation oncologist to know where the original tumor was, so they can plan their radiation and the boost. And then the next de-escalation, as I told earlier, was to prevent or avoid lymphedema. So lymph nodal assessment provides prognostic information. So if more nodes are involved, the outcomes are going to be poor. And if nodes are negative, the outcomes are better. It also provides information based on which we decide adjuvant therapy. So node positive disease, node negative disease, based on which we decide chemotherapy and radiotherapy. And then also, obviously, we want to remove axillary clearance of involved nodes. Also offers disease control, local and regional disease control. So for all these reasons, axillary clearance is done. So from our, going back to our McGregor days, where we understood the anatomy of the axillary lymph nodes. So the drainage from the breast, the anterior chest wall, the lateral chest wall, and the posterior chest wall, all of this, and the arm, all of this drains into the axillary lymph nodes. So from the breast, all the lymphatics drain into the subareolar plexus of SAPI, just under nipple areola complex. So first, they all directly don't go into the axilla. They all empty into the subareolar plexus just under the areola. And from there, one or two main channels go up to the axillary node as sentinel to reach the first echelon of nodes called sentinel lymph nodes. There are some directly draining nodes as well. So and then you have about 5 to 6% of the lymphatics go into the internal mammary nodes. So our job as surgeons is to identify the first echelon of lymph nodes. So so it's like the principle is like a guard. Sentinel means a guard, a guarding lymph node. So in a building, you have a security fellow sitting downstairs. So anybody wants to invade us, they have to overcome the security first to come inside the building and attack us. So similarly, the same concept. The first set of lymph nodes, the sentinel nodes, if you pick them up and then send it to the pathologist, they do a frozen section and tell us if there are metastatic cells in those lymph nodes. Now, if those lymph nodes do not have metastatic lymph nodes, then the probability of other lymph nodes having metastasis is rare. So therefore, you stop your axillary dissection there or axillary surgery there, and thereby avoiding a more aggressive treatment and more aggressive axillary surgery and avoiding lymphedema. So we use methylene blue. So earlier we used to use patent blue that has a slight risk of anaphylaxis, and it takes and it's not easily available here. Isocyanine blue was used in the US. It has to be reconstituted. It's available as powder and it's a messy affair. Methylene blue is easily available. It costs only 60 rupees. Only thing is we have to remember to make it subcutaneous. If it's intradermal, the skin will necrose and she will have a large ulcer after the surgery in the nipple areola region, and it can be quite devastating. So it has to be under the skin, beneath the skin. So when you inject this blue dye, about 1.5 ml, and then massage the nipple areola complex, then when you open the axilla, so you make a small 2-inch incision or 1-inch incision in the armpit, and you see when you open the layers, put in a retractor, you see a nice blue looking lymph node. So this is the sentinel node. So we take it out and then send it for, sometimes there are more than one, definitely more than one. So we take out these sentinel nodes, send them for frozen section. And in the frozen section, if they tell that it is clear of, it is negative for metastasis, that we don't do anything further. We just close up and come. Suppose there is metastasis, then we have several options in front of us. So depending on what we do, we may do a clearance or decide to radiate the axilla as a part of breast radiotherapy. So that is as far as surgical developments are concerned. And as far as radiotherapy is concerned, so like I said, from moving from cobalt machines, we moved to linear accelerator, and using the linear accelerator, the techniques to do this fast, techniques to conform the radiotherapy, modulating the intensity, image guided radiotherapy, all this developed. And then on the left side, the risk is irradiating the coronaries, and particularly if you do the internal mammary nodes. So therefore, we wanted to minimize, so patient gets cured of breast cancer, but then develops coronary related issues. We see that in the post-op, especially in patients exposed to anthracyclines also. So in order to decrease the morbidity associated with radiotherapy on the left side, we use a technique called deep inspiratory breath hold. So this is an additional software-based technique that is evolved, which reduces the heart-related damage with breast radiotherapy. And then fractionation. So we all know that radiotherapy is given over a period of time. You cannot give all the 50 gray in one shot. So we fractionate, say, 2 gray for every session over 25 sittings. So this is prolonged. Many outstation patients make a choice not to have radiotherapy because of the time. And with the prolonged fractionation, it also increases the machine time, and the machine is not available for many patients to use. So then the hyperfractionation technique may increase the dose per fraction every day, but then compress it to, instead of 5 weeks, compress it to 3 weeks and achieve the same result. This is called hypofractionation. And this proved to be equal in terms of outcomes as far as cosmesis and recurrence rates. And then now we have what we call as the fast forward therapy. It's where we complete the entire radiotherapy in 5 days, where we increase the fraction to a much higher number and compress it all in 5 days with a total lower dose. So which in good risk patients, it works very well. And there were developments, and you can't not mention development in chemotherapy and targeted therapy. So in the 1970s and 1980s, it was CMF treatment, cyclophosphamide methotrexate and 5-fluorouracil. So when I did my MBBS and the early part of the training, this was the only chemotherapy that was known. And then anthracyclines were introduced, and then the third generation chemotherapy like taxanes were introduced from the bark of this tree. Taxanes were extracted, and then the HER2 positive disease, which I already mentioned, Dennis Slayman worked on this and developed anti-HER2 treatment. So the first thing that came about was trastuzumab. Several trials proved that it had a definitive advantage on overall survival in patients with HER2 positive breast cancer. And then other HER2 agents, combining trastuzumab with another agent called pertuzumab. Then you have dual therapy, and then you tag chemotherapy to this targeted treatment, where this goes and delivers only the HER2 positive cells. So thereby there is not much side effects. So what we call as TDM1. So all of these are available now for use, and these are given intravenously. The only major side effect that we've seen is sometimes cardiac related morbidities, particularly when combined with anthracycline. So delivery becomes easy now. So instead of now IV treatments, patients can have dual therapy now as a subcutaneous injection, just like insulin. And it's so simple to deliver, and definitely has improved acceptance amongst patients. And so this is also easily available, and now available in our country too. And for hormone positive breast cancer, in breast cancer that is dependent on estrogen to grow, via estrogen receptor, progesterone receptor positive treatments, the earliest of targeted treatment that we know for the last 30 to 40 years is tamoxifen. So tamoxifen blocks it is an estrogen receptor modulator. So the estrogen receptor is a nuclear receptor expressed by over 60 to 70% of breast cancers. So this tamoxifen goes and blocks the receptor. It's like a musical chair. So it goes and occupies the receptor. So estrogen cannot go and bind to the receptor, and therefore downstream signaling does not happen and cell division does not happen. So tamoxifen is one of the earliest known targeted therapies. And then came aromatase inhibitors. In postmenopausal women, in spite of ovarian shutdown. So we all know there is extra ovarian sources of estrogen, particularly in obese people. Fat itself is a source of estrogen through the androstenedione pathway, through the catalyst of the enzyme called aromatase. The androstenedione gets converted to estradiol. So now we have aromatase inhibitors where the aromatase is blocked, so the androstenedione does not get converted to estradiol. So this is the same principle that you exploit in infertility treatment. We use it for breast cancer. So it blocks the estrogen levels. So it is used in postmenopausal breast cancers. And then we also have newer agents like CDK4 inhibitors like palbociclib and ribociclib, which are useful in strong ER and PR positive patients who are HER2 negative. So this is specific targeted treatment for ER and PR positive and HER2 negative patients. And now abemaciclib is a new drug, the wonder drug that is now introduced for a heavy node positive ER positive patients as adjuvant therapy for 2 years. So this is known to reduce the risk of relapse. So, and then the triple negative disease, where HER2 is negative, estrogen and progesterone negative disease is always was a feared disease, because you don't have targeted agents. You can't give hormone therapy. You have to rely only on hormone therapy, chemotherapy. So therefore, the outcomes were not as great. So now we have targeted therapies for triple negative disease as well. Is pembrolizumab. So this is now used in the neoadjuvant setting, and we're seeing very good pathological complete response rates with use of pembro along with chemotherapy. And in BRCA positive patients, targeted agent like olaparib is also now available and used in an adjuvant setting where we know that there is a definite mutation. So these are all the advances that are happening in the medical oncology sphere. So to summarize, surgical treatment was the first effective treatment for breast cancer, and it still remains the most important treatment modality with curative intent, along with surgery. And then we have other modalities like chemotherapy, radiotherapy, targeted therapy, and all that. And so it shifted from extensive, highly morbid procedures to the modern concept of obtaining the best possible cosmetic result in tandem with appropriate oncological resection. So the ever-growing comprehension of breast cancer biology has led to substantial advances in molecular diagnosis and targeted therapies also. So the understanding of breast cancer micro and environment is still, there's a lot that needs to be done. It represents a critical opportunity for better diagnostic modalities and treatment. And collectively, all these improvements will continue to push all therapeutic interventions, including operative treatment, towards the goal of becoming more and more focused, targeted, and less morbid. So thank you very much. I think that's it. Yeah.
Thank you, Selvi Radhakrishna. That was a wonderful presentation.
Thank you.
Now we are moving to Dr. Jayashree's felicitation. Dhanalakshmi? Or are we continuing?
Yes, ma'am. Shanti, ma'am. 1 minute.
Happy
Yes.
to have Dr. Jayashree Srinivasan here. She had already been introduced. So I would request a guest of honor to address us.
Madam Shanti, madam. And Jayashree, madam.
Yes, I'm here. Am I
Please,
audible?
ma'am. Yes, ma'am. You are very much audible, ma'am.
Good evening, everybody. At the outset, I would like to thank the Chennai Menopause Society and Oxy, Dr. Shanti and Dr. Dana and Dr. Jairani for inviting me here, and also for conducting this sort of meetings, which would help the youngsters really. And I congratulate both the teams on bringing out the third issue of Model. Again, each one should show interest in contributing to this and also to read that. That will lead us to betterment. Okay. And congratulations, Dr. Selvi, for such a wonderful lecture on how to manage a case of malignant breast tissue. But my concern is, I'll tell you, with due apologies to the surgeons, see, management of breast diseases has been snatched away from the gynecologists long ago. But still, the silver lining is that we still have a hold on it, how we can do the prevention part of it. So the onus is on the gynecologists and the obstetricians. It is an opportunistic examination that is offered to you to look at the patients. Whenever a gynae complaint comes, don't just look at the uterus and leave her alone. You have to necessarily look at the thyroid and palpate the breast, so that any doubt you can send them for further management. That's what I would like to impress upon you. And with this, and still we have further management of this overt malignancy. All this will be done here, but the basic thing is prevention. So all the gynecologists, take it into your hand, and the youngsters, please don't leave the breast without examining. My PGs will very badly fail if they don't do the breast and thyroid examination. So please, please, this is my request to all the gynecologists. Go ahead with preventing the disease. Thank you so much. And I wish the program all success. Thank you.
Thank you on behalf of Chennai Menopause Society, ma'am. And we will move on to the next speaker of the day. I request Madam Veni Madam to introduce the next speaker, Dr. Samandeshwari Mahesh. Veni Madam is here?
Yes.
Yes, Madam.
Good evening. Thank you very much for giving me a chance to introduce Dr. Samandeshwari Mahesh. And she is the radiologist, Apollo Hospital, and senior radiologist, Apollo Clinic, Portfolio. And she is the junior consultant. And in addition, she is a visiting radiologist, Madras Medical Machine. Her education, she is a MBBS at Madras Medical College and her MD in Madras Medical College. And this association, member of the Breast Imaging Society. So I welcome Dr. Samandeshwari to give a lecture on latest in breast imaging.
Let's stop sharing Samandeshwari so you can.
Good evening, everybody. I'm here to talk about the breast cancer screening and latest modalities. And today I'm in front of you. Because of my professor, Arka Gejraj, I'm thankful, grateful, and blessed by him. I had a great opportunity to work with him. We talk about breast cancer because 1 in 8 women develop breast cancer in their lifetime. The risk factors for breast cancer is age. As the age increases, the risk of developing breast cancer increases, and most are diagnosed on women in their 50s. Women with genetic mutations such as BRCA1, BRCA2 have higher risk of developing breast and ovarian cancer. And early start to menstruation around 12 years of age and late menopause after 55 years exposes a woman to hormones for longer periods, which increases the risk of breast cancer. And they have a family history of breast cancer or previous radiotherapy. The external risk factors are the dense breast. They have more connective tissue than fat, which can sometimes difficult in detecting tumors through a mammogram. Inactive lifestyle, being overweight or having obesity after menopause, consumption of hormones for HRT, especially during menopause, some oral contraceptive pills, and pregnancies after the age of 30, and no breastfeeding, and never having a full-term pregnancy, and even an alcohol consumption can increase in breast cancer. The common symptoms we all know, not everybody present with a hard lump. Some people, they do come with a thick area or as a dimple or a nipple crest or a warmth area or a bloody discharge from the nipple or a bump, or you can just see as a growing vein, a sunken nipple, or a change in the shape of the nipple or an orange peel appearance. So it's a must, like every woman should have a breast self-examination, either in front of the mirror or lying in the bed or during the shower, and she has to move her fingers, roll over up and down or a circular movement to find the lump on her own. When to start mammo screening? At 40 years and above, or earlier if they are risk factors, and an annual follow-up. You don't have a family history and still you want to have a mammogram screening every year? The answer is yes, because 70 to 80% of women detected with breast cancer do not have a family history or any other risk factors. So early detection is something very important, which helps in curative and because breast cancer is a curative and treatable disease, you can reduce the extent of the spread, less extent of surgery, and lowers the need for chemotherapy and increases the life expectancy. What is mammography? Just an imaging of the breast. There are 3 types of mammography. It can be diagnostic, screening, or opportunistic. Screening is asymptomatic patients where we do early detection of breast cancer. And diagnostic is they come with a symptom or in high-risk patient to rule out underlying cancer. Or opportunistic, like they come for some other complaint, the doctors, we push them for a mammogram. Mammogram and ultrasound are the first line of investigation for breast imaging, and sensitivity to 2D mammography in the screening for breast cancer is 83 to 95%. As you all know, what are the indications? A screening at 40 or in asymptomatic, we can do it at 35 years where there is an increased family history. Symptomatic at 35 years with a lump or suspicious of malignancy, in search of primary occult in people with metastasis, surveillance after lump excision or lump in the male breast. The contraindications for mammography are simple nipple discharge, severe nipple discharge, large palpable mass, inflammation, women within reproductive age of 50 to 40 years, uncooperative patient, and large mass. The different modalities in diagnosing breast cancer are 2D mammography, 3D tomosynthesis, MR mammography, contrast enhanced digital mammography, elastography, and molecular breast imaging. For 4 decades, the gold standard in breast imaging was screen film mammography. This is how a mammogram pictures are taken, a craniocaudal view or a MLO view, where the woman gives a 45-degree tilt, and this is how the images are mounted. Both should be symmetrical, and the marker should be kept in the lateral quadrant in the craniocaudal view. That's how when we read mammogram, we say upper outer or lower medial. So the side mark is very important. How to report mammogram? There is a lexicon where we have to say about the breast composition, the masses, what you see, the asymmetry, the architectural distortions, calcification, and the associated features in one report. The breast composition, according to ASIA guidelines, it is classified as A, B, C, and D. A is a complete fatty breast, B is scattered fibroglandular densities, and C is heterogeneously dense, and D is completely dense. The mass, the space occupying lesions, they should be described according to the shape, margin, and the density. It can be round, oval, or with irregular margin. The margins can be well circumscribed, obscured, or it has microlobulation, indistinct margins, or speculated. The densities can be low density, equal density, or high density. This is how it's a fat lipoma. Here it's a fibroadenoma. Asymmetric density, here there is no mass as such, and it is just an area. It is moving automatically. The asymmetry can be a global asymmetry or focal asymmetry or a developing asymmetry. The calcifications can be described as diffuse. Benign calcifications can be diffuse, regional, group, linear, or segmental. The benign calcifications can be just skin calcifications, milk of calcium, rod-like in plasma cell mastitis, dystrophic popcorn or rim calcifications in fibroadenoma, vascular calcifications, and punctate calcifications. The suspicious malignant calcifications can be amorphous, fine pleomorphic, coarse heterogeneous, fine linear, and linear branching calcifications. And when we do calcifications, we should ask the patient to come for follow-up, and magnified view should be taken to see the better visualization of these calcifications. The associated features like skin retraction, skin thickening, nipple retraction, trabecular thickening, and adenopathies are all has to be described. So in total, when we report a mammogram, we need to grade them according to Berard's. If it is 0, the thing is incomplete. If it is grade 1, it is normal. 2 is benign, like cyst, and 3 benign is fibroadenomas, where you need a short-term follow-up. 4 is suspicious malignancy. The biopsy should be considered. And 5 is highly suggestive, and even it needs biopsy. And 6 is a proven malignancy, controlled biopsy and treatment planning. So there are limitations of 2D mammography because the 20% of cancers are missed. Sensitivity decreases with increased density, and about 10% are called for additional views. So 3D, there comes the 3D mammography, which is safe and takes several seconds longer. It is not available in all places. It helps in early detection of abnormalities. It enhances the borders of the lesion and help in precise localization of the lesion. It reduces the false positive results and solves the problem of tissue overlap. Breast tomosynthesis or 3D mammography are the same. Here, there is a moving X-ray tube and the digital detectors are used. The X-ray tube moves an arc during exposure of 10 to 25 degrees. A single compression, you get a complete data of the breast. Multiple sizes of breast are taken with various angles. It is like turning a book page. Here, you can see an X-ray tube moves in an arc across the breast, and series of low-dose images are taken. This is how the tomo images look. So you get a better margin. Here you see a dense breast where this is not seen properly. In 3D tomo, you see the clear margin. And finally, in the map view, you can see the margin so beautifully. It gives the highest sensitivity. This is a 2D image of a dense breast. You just see an area of, it looks absolutely normal, whereas in tomo, you see a area of distortion. And finally, in the tomo, you could see a speculated mass. And every case of mammogram, we do an ultrasound screening, and the ultrasound describes whether the lump, what you see in mammography, is a solid, cystic, or cyst with some complex lesions, whether it's a ductal dilatation or is there any intraductal papilloma. In our country, we subject every mammogram ladies for an ultrasound screening. Along with ultrasound, the latest is the elastography. This is done as part of ultrasound exam because breast cancer tend to be firmer and stiffer than surrounding breast tissue. So the breast is compressed slightly to show the suspicious areas. It is useful in telling an area is likely to be cancer or not. There is different grading in elastography from 1 to 5, whether it is benign or malignant. Then comes the contrast enhanced mammography. It is a quick breast imaging technique which combines 3D tomo digital mammogram with an intravenous contrast. Why this is required and where? This is used in female with breast cancer and dense breast in evaluation of any palpable lump, pre-surgery planning. What are the benefits? It increases the cancer detection rate, gives better information about the extent of newly diagnosed breast cancer, effective in evaluation for breast cancer treatment planning. It saves time and minimizes the anxiety to single investigation. It is unaffected by dense breast, lower cost and procedure time, effective alternate to breast MRI, where MRI is not tolerated. So, what is the principle in CEM? Contrast is known to target malignant cells, malignant area. So, based on the principle that rapidly growing tumors requires increased blood supply to support growth. So, when contrast is circulated in the blood, the abnormal blood vessels leak contrast, which accumulates in the tumor. So, this mammography shows abnormal areas in dense breast, parenchyma, hidden cancers in asymmetric density and the extent of the tumor. How it is done? Usually we use ionized CT contrast agent. During the injection of the breast is not compressed and the patient will be in sitting position. After injection, there is a 2-minute delay and the patient breast is positioned and compressed. 2 exposures are required, low and high kV exposure for each projection of the breast. You cannot see the contrast in high or low kV images, but you can see only in the subtracted images, and only the low kV subtraction images are stored in the packs. Here you can see a 2D image and you can see some distortion. The tomoslice shows a better image and the contrast mammography delineates the tumor very clearly. This is a dense breast. Nothing is seen here, where tomo shows an area of speculation and the contrast mammography highlights the enhancing mass clearly. Next comes the breast MRI. It needs a dedicated breast coil. The patient lies in a prone position. It is the screening tool in women with high risk. It is valuable tool in diagnosis of additional cancer in the same breast. It is more sensitive in invasive lobular cancer, which is missed in mammography. It detects duct-related pathologies and intraductal components. Its preoperative MRI is more accurate in assessing the extent. And these are we need a 1.5 Tesla machine, and these are the techniques to acquire the images. This is the machine. This is how a woman lies down on the couch, and this is the breast coil. These are the images to show the T1 and T2 weighted images, the speculated mass and the non-mass enhancement. You can see an asymmetric enhancement and clump enhancement in the MRI. And the latest is a newer abbreviated MRI or a fast breast MRI. Fewer images are taken over a short period of time. It's a possible screening test for breast cancer in dense breast. It provides same information as a standard MRI and it is cost effective. The newer experimental imaging are CT mammography, that is called as molecular breast imaging, where technetium 99M is injected into the blood and a specific gamma camera are used to see the tracer. It is used in follow-up of tumor and in dense breast. Somebody is moving the slides, yeah, faster. CT and PET-M.
Only you have control, Tamlishwari.
Pardon?
Only you have control over the slides.
Okay. PET-CT and PET mammography are used, and all these molecular imaging are done latest to find the clusters of cancer cells within the breast, but the radiation in these modalities are high. Last come is the breast biopsies. We know before we do only FNAC or co-biopsy for the breast lump. Now we have stereo biopsy, vacuum guided biopsy, and vacuum guided excision of the breast lump. This is how core biopsy done under ultrasound guidance, and the needle is put inside the mass with ultrasound guidance and small cores of breast tissue. No, it's moving on its own. The other is stereotactic breast biopsy, where the 3D image guides the biopsy needle to the exact site of the breast lump. It is used to take biopsy from the microcalcification. The breast will be firmly compressed between the two plates, and mammogram produce stereo images and images of the same area in different angles to determine the exact location of biopsy. This is how a woman is sitting during the procedure. Here, the microcalcifications are localized, and the biopsy gun is stereo biopsy is positioned.
Sahiti, can you just call up Dr. Samlishri and find out?
Ms. Govardhana,
No, it is Dr. Samlishri is, I think it's not at all. Maybe she's got another 3-4 slides to this one. We'll find out whether she'll be able to join.
Dana, is she allowed to continue?
Yes, ma'am. But where is she? She's not in the field, madam. I'm trying to call her up.
Good evening.
She's coming back. Just two, I think 2 or 3 slides extra. She's almost at the end of her talk. We'll wait for her. She's sharing it again. Meanwhile, Dr. Kundavi can be ready to introduce the next 3 tripartite doctors. Doctors are going to make the trialogue very interesting.
Dana ma'am, there is which session after the talk, ma'am?
Yeah, that's what Dr. Deepa is held up with a placenta accreta. So she might join at the end of the program.
Okay, ma'am.
Then unmute Samlishri. Unmute. Unmute her. Yeah, we're able.
Hello.
to.
So the benefits of vacuum assisted excision is you get more tissue to get greater detail. It's a less invasive than surgical excision. It reduces the recovery time. The risk is bruising, pain, bleeding, scarring, and fainting attacks. I want to share a few cases. A lactating mother of 26 years was referred to me for ultrasound aspiration of pus as she had a left breast mass for 3 months. And this is the ultrasound picture showing when I did the ultrasound, I could see a skin thickening of an inflammation, but there was no pus to aspirate, and I could see a lot of my small calcifications, and there was an enlarged node with loss of fatty iron. So I subjected the female for the mammography, and I could see a diffuse microcalcification where the whole breast is involved, and it was a lactational mastoid malignancy. So young Earl, for 26 years, I subjected the girl for a mammography for want of diagnosis. So we radiologists should decide which one is needed for each patient. 45-year lady with a breast lump. She comes, so the history taking is something very important. Here, you see the mammography, it looks absolutely normal. Because we took the history and we examined the patient, the lump was seen here as a very small, tiny lesion. So you have to take the history, or else I would have missed the lesion. And it was only a lobulated fibroadenoma. So history is very important in doing mammogram. And this is a 33-year female with a discomfort in breast, and because her mom had a cancer breast. So she came in 2021. I could see a small area of calcification and nothing was seen in ultrasound. I told her, no, we keep her under follow-up. Next year when she came, the calcifications were little more, and I could see some ducts with some microcalcifications. So did the biopsy, and it turned out to be a TCIS. So when a patient is advised for a screening, they should come for a regular follow-up, and there we can help them in diagnosing cancers at an early age. This is a 40-year female who came for a routine screening. The mammogram, it looks absolutely normal. You cannot find any mass lesion, except you can see an area of asymmetric density in both the views, craniocaudal and MLO. So as radiologists, we have to go concentrate that area while doing screening. And it was only a small cyst. Like this, even a small cancer can be missed if you're not concentrating on the density and the symmetry. So mammogram is something very important, and the radiologist's dedication to the patient is also important. So all of us do get your annual mammogram done without fail, and we are here to believe every life is priceless and early detection saves life. Thank you.
Thank you, Dr. Samundiswari, for your nice presentation. You have dealt with the high risk factors for the breast cancer, and you have dealt about the mammogram, the indication, contraindication, and various modalities of imaging. All your pictures, especially images, were crystal clear. And this one, the last word, like a cancer cervix, early detection definitely helps a mother to survive. And this early detection is possible only by imaging. Thank you.
Allow me to. Saidi, will you allow me to share my screen?
Yes.
Yes, ma'am, you can share me.
It's not getting shared. Can you share from your end?
Okay, ma'am.
Yeah. I request Dr. Kundavi to introduce the speakers for the last session. If Deepa madam is free, Deepa Tangamli madam, and she's free after the
Ma'am,
emergency.
shall I launch
can.
quiz questions now or at the end of the program, ma'am?
You can.
Hello, ma'am.
Madam, how do you do it, madam?
Yeah, now.
Okay, do it now.
Shall I launch the questions?
Yeah, please.
Okay, ma'am. So first question. Ma'am, Shanti ma'am, can you please read the question?
Yes, Mas. Yes, Sakiti. So what is the role of screening mammogram? Single choice, 1, finding mass before it reaches 1.5 centimeters, 2, 2.5 centimeters, 3.5 centimeters, 0.5 centimeters, and 1 centimeter. Single choice.
Is there a second question in the session?
Yes, ma'am. Last 5 seconds for the
Okay,
delegate.
okay.
Time up. So second question.
When will you refer average risk patient to screening mammogram? 30 years, 40 years, 50 years, 35 years, 45 years.
Last 5 seconds. Time up. Yes, ma'am. Only 2 questions, ma'am.
Okay, okay. You just collate it and then send it, ma.
Okay, ma'am.
Share the screen, and I request Dr. Meenloche Madam to introduce the she and Uday Madam to introduce the speakers for the next tripartite conclave. Meenloche Madam, over to you, ma'am.
Have the
Are you able to see the
So
screen,
it's my
ma'am?
proud privilege to introduce Dr. Ramya Ramakrishnan, who is the Associate Dean Academics, Professor of Surgery at the Apollo Institute of Medical Sciences and Research, Chittoor, Andhra. She has done her diploma in minimal access surgery from the University of Strasbourg, France. She has completed advanced course in medical education, and she has also completed fellowship in advancement of international medical education and research, Ludhiana. She has special interest in breast and endocrine surgery. And she has been a UG and PG teacher and examiner for more than 7 years. She is an intercollegiate MRCS examiner for RCS Edinburgh and RCS PG. She has published more than 50 articles in national and international journals. She has authored 2 chapters in International Textbook of Emergency Medicine and also 5 chapters in Holistic Approach on Breast Disease. She is a member of the Academic Council of the Association of Surgeons of India. So, and
Thank you,
the
ma'am.
next, yeah, and she'll be part of the thing. And the next person whom we are coming under the tripartite is Dr. Sandhya Sundaram. She is I'm sorry. She is the head of clinical services pathology at Sri Ramachandra Medical College and University. She is an undergraduation she did from Burdwan Medical College, West Bengal, postgraduate from Institute of Basic Medical Sciences, Madras University, and recently completed her PhD from IIT Madras in December 2021. She has special interest in genitourinary, gastric, breast, and molecular pathology. She has been awarded Young Scientist Fellowship by DST for training in molecular pathology at V Center for Research, USA. And she has more than 89 scientific papers in national and international journals to her credit. She is a chief editor for the book titled Handbook of Pathology for Postgraduate Students. And she has the honor of writing the foreword for the most iconic book in pathology, Rosai and Ackerman's Surgical Pathology, South Asian edition. She has been awarded the Power Grant for Women for Research in Breast Pathology by the Government of India and BRNS Research Grant for cancers of head and neck. She has also been awarded Lalita Kameshwaran Gold Medal for publication with the highest impact factor in the year 2021 and high volume grant awardee in 2022 by Sri Ramachandra University. And the third will be none other than Dr. Bhavna Dev, and she is a radiologist, radio diagnosis, and she is at Ramachandra Institute of Higher Education and Research. And she is a professor and in charge of women's imaging. And she is the lead radiologist of breast imaging and interventions. And her areas of interest being breast imaging and interventions, MR guided focused ultrasound, musculoskeletal interventions, intraoperative ultrasound guided interventions. And her education and career had been at Amritsar and Ramachandra University. She has had a training in radio frequency ablation technique and fellowship from the musculoskeletal MRI from California and breast imaging and interventions from University of Miami. And she also has more than 60 publications in peer-reviewed national and international journals. And she has a teaching experience of more than 20 years. And she is the treasurer for Tamil Nadu Pondicherry chapter of IRIA and General Council member, Breast Imaging Society of India. So we have today with us 3 stalwarts who are going to tell us about all about breast, which is their very passionate subject, I believe, from their CV. Over to madams.
Hello, good evening, everybody. This is Bhavna here. Can I share the screen?
Sure.
Then Sandhya will
waiting.
take over.
Yeah. Share, Bhavna. So while Bhavna shares the screen, thank you, madam, for that beautiful introduction. I didn't think you didn't miss out even a single point. Thank you so much. And as you very rightly said, we are very passionate about this topic. And I think we have been in several forums. And I think it has been very aptly named Breast Friends Forever. I think that was a very masterpiece of a title that Dr. Dana has given to this session.
1 minute.
So,
I think it's going on. 1 second.
So we have a set of cases where we will discuss the clinical, the radiological, and the pathological aspects. These are cases which we have seen in our institution. And yeah, so shall we start, Bhavna? Are we good to go?
Can you see my screen?
Yeah, we can see you. We can see the screen.
Yeah, sure.
Dr. Dana, can you see the screen, madam? Yeah, okay. I think we can move on to the next slide. Yeah, so this is scenario 1, a rapidly burgeoning bump in the breast. This is the title we gave. And this is a 48-year-old female who came with complaints of lump in the breast for 3 months. And it was progressively increasing in size within this 3 months. And there was no family history. So here I bring in Ramya. Next slide, Bhavna. Ramya, what did you examine and what was your impression about this patient when you saw her?
So this was a 3 into 3 centimeter lump in the upper inner quadrant. Though it was mobile, it was moving with the breast tissue. Opposite breast was normal, and ipsilateral, there were no axillary lymph nodes. So this is a 48-year-old, right, lady?
Yes.
So she has a breast lump that moves with the breast tissue.
Okay.
So
Right.
I would be a little worried in this lady because any lump that moves with the breast tissue, we should rule out a malignancy, despite the fact that she doesn't have any axillary node.
Okay.
The other thing that comes into my mind, could it be what is called as a Phyllodes tumor?
Okay. Fine. So the clinical diagnosis, you say it could be malignancy bar Phyllodes, and obviously the next thing would be to go to imaging. And here I give it to our Dr. Bhavna. Bhavna, what is it that you want to do with this patient, 48-year-old? She's quite anxious. Yeah.
Yeah, we all heard last lecture, and it was very clear that, and then there was an MCQ also, that what imaging should be done at what age. So she is 48, so we will go ahead and do a X-ray first, X-ray of her both breasts, which is called mammogram. So we did an X-ray, and this is her X-ray mammogram, and we can see that there is a mass here, and you see the margins of the mass are clear in this area. You can see my arrow moving.
Yes, we can see it clearly.
They are clear in this area. However, the margins are not clear over here. So as Dr. Ramya was telling, and even in this picture, you can see that there is a little bit of haziness. This margin is not clear, though these other places it is clear. Okay. So if it is margin is not very clear and she is 48, so I would actually go ahead and do an ultrasound, because in India, we almost, whenever the patient comes, we supplement it with ultrasound. So ultrasound was done, and ultrasound, you can see that it is not a very beautiful looking fibroadenoma or something. At the same time, it does not look like very ominous, okay? It does not look like very suspicious, but it has multiple lobulations, okay? And it looks a little bit dirty from inside, and you can see that it has little bit of vascularity also. So I would see, we have a Byrad's lexicon, as Dr. Chamundeshwari was telling it in the last lecture. So I would Byrad it as like, Byrad's 4B or A. Means there is around 50% of chances of it being malignant is there. So if you ask my radiological possibilities, it would be either phylloids or it would be a suspicious mass.
Okay. Right. So then we go on to the next one. And here I think you did try to take a core biopsy, Bhavna.
Yeah. So the one, sorry. So can you see the question up?
Yeah, we can see direct versus image guided biopsy. So yes, Ramya, this is a question to you. Would you want a direct versus image guided biopsy? What would you prefer? And
I think currently, the standard of care is image guided biopsy. Why? Because about 15 years back, I used to do a palpable lump. We used to do a direct core needle biopsy or an FNAC by the pathologist. But the problem is sometimes you may not be able to sample the correct area, and you may get it out as benign, but ultimately the patient actually will be having malignancy. So it's always better to go image guided, and ultrasound, as Dr. Bhavna explained, will help us target the correct area for sampling, avoid necrotic areas, or
basically avoid the necrotic area.
Yeah, so that we have to keep you pathologists very happy, isn't it?
Yeah.
So we have to give the correct sample.
We get good cores. We are very happy to see good cores actually.
Yeah, you can see only whatever comes under the microscope. So it should not be necrotic tissue.
And
so
Bhavna, how many cores do you normally take out, Bhavna? I mean, just to when you do an image.
Actually, if you ask worldwide, they say 3 to 5 cores, but I have never taken more than 3 cores because our pathologists are good enough to give me result within 3 cores. Okay. Also, I just wanted to add this, that that when we do it under guidance, especially ultrasound guidance, we can first of all see that there is no area of necrosis. And now with the advent of elastography, which is almost there in all the machines, we can even see which is the hardest part of the tumor. Okay. And we can take a biopsy from that represented area. So actually we are, going
exactly targeting the area that you want.
Area which we need to do.
Okay, so I think you did a core thing.
Yeah, this is ultrasound guided core biopsy. You can see a needle through the lesion. This white color thing is a needle.
Just a point.
Yes.
Because we have a mixed audience.
Yes.
So basically, Bhavna, this is an outpatient procedure done under
ultrasound guided biopsy is done as an OPD procedure.
Yeah.
It's about patients. Most of the patients are done within half an hour. Like in and out time for the patient is half an hour, and there are there are no complications at all. Most of the patients go without complication. Only complication is if you are a new person and doing a biopsy, you might go directly vertical instead of going parallel. Okay, so that is what we have to. And some people, in less than 1% of people, they might have a mild bleeding or ecchymosis, which can be taken care of by giving a cold compression. So there is nothing to be worried about.
Yeah, done under local anesthesia, right?
Under local anesthesia.
Yeah. Okay. Thank you for that.
So so once Bhavna has taken some wonderful good cores, the challenges is, as she said very rightly, that we don't want necrosis. We want good cores, which has a lot of material. And here the role of frozen section in phyllodes. Now, Dr. Ramya very clearly said that the DD is between phyllodes, and a malignancy. So in that, the role of frozen section is important. Definitely frozen will help us to differentiate whether it's a malignant tumor or just a phyllodes fibroepithelial tumor. So there I would say, but then core itself will give a lot of information, and most of our diagnosis, we make it in core itself. I think so. With that, I think, can we go on to the next slide, Bhavna? Yeah. So in BIRADS, Bhavna, now that we think, between a fibroadenoma and phyllodes, are you able to very clearly distinguish between a fibroadenoma and phyllodes? And then I will tell you what the pathology challenges are.
Yeah, in ultrasound, it is difficult. Okay, see, sometimes when it is a pure fibroadenoma, we can say because it is very well circumscribed, oval in shape. So
Yes.
all those things are there. But when it comes to, when it starts like you, as you saw in this case, the margins are little lobulated. Okay, so this could be a fibroadenoma, but it will be very difficult for me to label it as fibroadenoma. So it becomes difficult for us to give phylloids, but we can give the possibility. But final verdict has to come from you. So this one, I would label it as a borderline. Because it has multiple lobulations. As you can see, it it is irregular in shape, and internally also it does not look very nice. Plus, there are some slits which are the radiological signs of it being a phylloid. So I would give it as a possibility of phylloids, but at the same time, I cannot be sure.
So let's see what the core biopsy showed in this case. Well, this is the high power view of the core biopsy, and Bhavna, if you can just help me point out the leaf-like areas. Yeah, so what she's pointing out is the flattened out epithelial area, and in the center, Bhavna, come to the pink center. Yeah, all that is a stromal area. There is quite a lot of stromal expansion, but cellularity is not much. It's kind of not moderately cellular, and it resembles the leaf, and that's why I put that picture. So this is classical of Phyllodes tumor. However, a cellular fibroadenoma also in some areas can look like this. So again, as I said, the challenges are we like to be diplomatic in our reports, and we say fibroepithelial lesions favoring phyllodes, so that if it turns out something, we can say we only favored phyllodes. So we just called it a fibroepithelial lesion favoring phyllodes. So that's what it was on core biopsy. And the next one, Bhavna, just go ahead. Yeah, so this is what, yes, Ramya, you did the...
Yeah, so we have done a wide local excision depending on the tumor breast ratio. This was a 3 into 3 centimeter tumor in a fairly large breast. So remember, Dr. Selvi was talking about oncoplastic surgery, wide local excision. The same principle is used to remove this lump, and maybe, it doesn't really require any displacement, replacement, etc. But the same principle is a wide local excision means 3-dimensional, 1 centimeter clearance is given. You can see that we have tagged the, sorry about the noise disturbance. We have we marked the borders, that is short superior, long lateral, using sutures, so that we know that all the borders do not have tumor. That is, we have done a wide local excision. So frozen has a role here. I would say that we take the help of the pathologist to look at the margin status, but not for diagnosis per se, because the core has told us whatever has to be said. So the patient was very happy after that when we said that what was the final histopathology? Was it benign, borderline, or malignant phyllodes?
So let's see that. So again, as you said, clearly explained wide local excision versus mastectomy. So in this patient, you did wide local excision, right?
Yeah, that's right. If the tumor is quite big and the breast is very
margins
small,
are free,
we end up doing what is earlier called a simple mastectomy. Simple by no means, it's a total mastectomy for the patient, but here we got away with a wide local excision.
So yes, so in the final specimen also, as you can see, there are these slit-like spaces, and there is a lot of stromal expansion. Those are the epithelial areas. And the stroma didn't look, while it was cellular, there was no mitosis. It looked bland. The cells did not show any atopia. And we give complete one face section. And as Bhavna mentioned in her radiology, she saw some slits that was in black and white. And here you can see it in color, the same slit-like spaces where the stroma has expanded and the epithelial elements are compressed. So our final HPV was indeed benign Phyllodes tumor. And just for information, next, can we just go to the next? Yeah, so this is how we divide, that is benign, borderline, and malignant. And for my pathology students, I say 3S and 3M: stromal cellularity, stromal atopia, stromal overgrowth, mitosis, margins, and malignant heterologous elements. So accordingly, depending on the mitosis, depending on the stromal overgrowth, and all the other features, we divide them into benign, borderline, and malignant. And this case was fell under benign Phyllodes. The margins were clear. So I think it was a complete excision. And I think patient went home happy. And yes, Bhavna?
Yeah.
Yes. So I think
the
yes,
take-home message from all of us would be a 48-year-old lady, whether she's premenopausal or perimenopausal, any breast lump, first thing is to rule out malignancy. So you have to follow triple assessment. That's what we have done. And thankfully, this lady had a benign phyllodes. She's very happy. But again, she has to be kept under a close follow-up, and both for clinical examination as well as imaging. So,
Bhavna, how long will you be? What is the follow-up that you would advise? I mean, what would you say for this patient? Benign phyllodes, margins are free.
No, yeah, now since her phyllodes tumor is out, so she will come in for usually the surgeons call them after 6 months for an ultrasound. But with mammography, we'll go yearly. Since
So
she
shall
did
we move
not
on?
have any other tumor, so and only this was there on ultrasound, so we will just see her bed after 6 months when she comes to the follow-up with the surgeon, and we'll see if any hematoma or anything else is there, residual tumor. And obviously there is no residual tumor now, but 6 months when the patient comes to see the surgeon, they come to us for ultrasound, but her mammogram will be done yearly.
But shall we move on to scenario 2?
Any questions anybody wants to
Yeah,
ask?
anybody questions if they want to ask? I did see a couple of nice comments. Yeah. Okay, shall we move on to the next case, next scenario, and then maybe we can even take questions at the end. Yeah. Yes. So this was scenario 2, and we called it a reverse presentation, and I'll just explain why we said that. 77-year-old lady with a breast lump, 2 months, family history positive, but this time the daughter had carcinoma breast detected 3 years earlier. So this was actually the daughter had breast carcinoma earlier, and then the mother was detected with CA breast. And then I think, yes, Bhavna? Yes, so Ramya, when you examined, this is what you had put down in your notes, if you can just explain.
yeah, basically, again, this lady had a small lump, I would say 2.5 into 2.5 upper inner quadrant. Again, moving with breast tissue. And remember, always, again, a word of caution, malignant breast lumps need not be hard. So don't go with the idea that only hard lumps you should worry. Sometimes a hard lump will be a calcified fibroadenoma.
Yes.
So it is always 90%, 95%. It's a firm lump that will actually make us believe it is not anything to worry about. But here it's a firm lump, again, moving with the breast tissue. That means it is infiltrating the breast tissue, basically. But small lump, and this lady again did not have any axillary lymph nodes. But keeping in view of her age and the family history, that is, her daughter had CA breast, I would be very worried. I would like to rule out a malignancy again.
Yeah. Yes, I think then
the opposite breast and axilla we always examine was essentially normal, so were the supraclavicular areas. So it was only a unilateral, clinically palpable lump in this lady.
Okay. So what imaging, Bhavna? What is the next thing, next set of?
Yeah. So obviously, again, she is a 77-year-old lady. Okay. So I see a lot of people, okay, they say that, because she is 77, so they say just do ultrasound. Okay, because they think it's like both ways, when she's too young or when she's too old, they also think, after 60, they start thinking it will hurt. So they just refer it for ultrasound, but that's a wrong thing to do. So we need to do an X-ray, 100% X-ray. Okay. Because a lot of cases we find these microcalcifications, which can only be picked up on X-ray mammogram.
Okay.
And which are the early signs of malignancy. So
and
here
they're able to tolerate it well, right? They're able to tolerate it.
Now it's not that only but most of the places, I think they have got replaced by tomosynthesis. And actually, I tell you, it takes only 4 seconds compression. So I think it's worthwhile taking that much pain. Okay, it's not that the earlier days you will be compressed, 2-3 minutes. It's just few seconds. So in this case, we are seeing that there is a lump which is clearly seen, but you have to see it very carefully. Okay, there are signs of malignancy in lump, which I, as a radiologist, will call it as a suspicious thing. You can see that there are small lobulations here.
Yeah.
It is not very well circumscribed, and also there are few spiculations. If you can see it, I think it's quite clear because her breast is totally fatty, so this is very clearly seen. So again, here also you can see there are microlobulations. Yeah. And when we did ultrasound, again, you can see that there are some lobulations, and this side looks very, irregular, and it is not smooth. So again, I will put it as a obviously we do axillary ultrasound is done as a part of breast examination, very important radiologically also, because at least what we practice is if we are doing a biopsy of suspicious Mars, at the same time, if we have a suspicious lymph node, we do FNA, so that, it becomes easier later on. So this was BIRADS 5 mass, suspicious.
Straight away you called it a BIRADS 5 mass, which means highly suspicious, right?
Yes. And then we obviously went ahead with the ultrasound guided biopsy. This is how the biopsy has been done for her. And this
is what we got. And Bhavna, if you can point out to those streaming cells. Yeah. So that is your tumor cells, which are completely, you can see them all come out of the ducts and they're all over the place. And that pink stuff material that you're seeing is the desmoplastic reaction. And some areas you can also see where Bhavna is pointing is all the islands of tumor cells trying to form some small glands. So definitely here the entire lobularity of the normal breast is disturbed. And this is a no doubt case, straight away I agree that it is invasive ductal carcinoma, not otherwise specified. There's invasive mammary carcinoma, NST. So NST, and then immediately, of course, when I call Ramya, it's a standard practice that we can straight away do reflex testing, which means that once we see it is CA breast, we can go ahead with the ER-PR HER2/neu. And as you can see on the right-hand panel, just point out to the ER-PR. Yeah. So yeah, the cells are completely negative. So it's ER-PR negative. And below, as you can see, the brown color has taken up very beautifully around the cell membrane. So this is HER2/neu, strong HER2/neu positive, ER-PR negative. So this is the molecular type, HER2/neu enriched subtype of molecular subtype of breast carcinoma. And we do all these IHCs in the core biopsy itself because the material is good enough and the patient can, you can go ahead with the treatment. Yes, Ramya, any points there you want to make out about ER-PR and HER2?
Yeah, usually in this age group, no postmenopausal 77 plus.
Generally, yeah.
We would expect usually a ER-PR positive tumors and not so much HER2/neu.
Yes.
But this lady surprisingly had a HER2/neu, but anyway, that has to be dealt with post-op, definitely.
So I think now the management, Ramya, now that you know she is HER2/neu enriched breast carcinoma, and what would your 77-year-old, what would be your...
Yeah. So age is not a deterrent to offering breast conservative surgery to this lady.
Yes.
So ideally speaking, look at a tumor breast ratio. The breast is quite large, lot of fat, and the tumor is pretty small. If you can go back to the mammogram. So the tumor breast ratio is very good. Though it's a little bit in the inner quadrant, but still we can offer breast conservative surgery. But before that, I would always check with the radiologist as to what about the remaining breast? Is there any multifocal element in it? And what about the opposite breast? Is it multicentric? What are we going to do? But more important for breast conservative surgery is the remaining breast should not have any suspicious impalpable lesions or microcalcifications or architectural distortion. In that case, I would not offer her a BCS. So we would like to again go through the mammogram with the radiologist before we really talk to the patient and offer them something. You should not confuse them. And of course, she has got axillary nodes, which were not clinically palpable, but very much you can see it in the mammogram. So we FNA the axillary nodes, like Bhavna said, ultrasound guided FNAC. If they come positive, then they go for axillary dissection. If it is negative, like Dr. Selvi beautifully explained about sentinel lymph node biopsy. But before I offer BCS, I need to know about the remaining breast, any lesions. Bhavna, can you help us with that?
Yeah,
so point with, yes, Bhavna, go on. Yes.
So what happens is when now more and more of patients are they want BCS, they want their breast to be saved and breast conservative surgery they want. And our surgeons are also doing very wonderful job. They are giving us good cosmosis. So now before actually, ideally speaking, any good breast surgeon would do a investigation which they will want to say, as Ramya ma'am was telling, that they would like to see if any other masses are there in the same breast or anything else is there in the other breast, because treatment totally changes. So now we can find it out with two things. One is contrast enhanced mammogram, which can be done immediately when you are doing a mammogram for the patient. You can give the contrast to the patient. How we give it for CT scan, we give it for mammogram also, and we can take a contrast mammogram, or we can do an MRI. Okay, so any of these two investigations ideally should be done before any BCS. So this was the case. Now you can tell. So these are the mammogram pictures of some other patient. Okay, our patient did not have anything on the same breast or the other breast. Okay, she only had one lesion. As you were seeing, it was a fatty breast, it was seen. But this is another patient. I just thought it will be a good discussion. So we can see that there is a mass here, and we did a contrast mammogram. When we did a contrast mammogram, we saw that there is another lesion in the opposite breast also. So I think with this, the total the concept of breast conservative surgery will not be there now. So I think you can give some opinion of yours, madam, now.
No, now the same breast, if it doesn't have any other lesion, I would have still offered breast conservative therapy. But we see a lesion on the opposite breast. When you see a lesion on the opposite breast, is it a metastatic lesion from this breast, or is it a new primary?
Yeah.
So if it is metastatic, there is no question of surgery at all. We have to go for systemic therapy. If it is another primary on the left side, each breast is treated separately. There is no distant metastasis. Both breasts is treated separately. Still, you can offer breast conservative surgery on both sides.
And both sides, the IHCs have to be done for the molecular.
IHCs, yeah, exactly. To make sure
something which is
if
sure that
IHC, yeah, exactly. Thanks, Sandhya. If IHC on both sides are the same, like same HER2/neu enriched infiltrating ductal carcinoma on both sides, then I would really worry this is metastatic. That is infiltrating ductal carcinoma, but it's ER/PR positive, HER2/neu negative. That means
then it's a
another
different
primary on the opposite side. So all these combinations can occur in patients, and you should not be surprised at it. So you have to have your mind open and then alter the treatment. So that's why you said, no, it is what is it called? Personalized medicine that you
precision
offer.
medicine,
Genomic medicine, personalized medicine. Each person has to have a tailor-made program or treatment protocol offered to them. And so this becomes vastly interesting now and needs a lot of counseling, discussion. And this is where Selvi beautifully brought out the thing about the breast center, where there's a multidisciplinary team who sits and decides what will be the most scientific way to go about. And that decision or that thought process is shared with the patient. Then the patient and the family decide what is to be done. So here comes the role of the multidisciplinary tumor board, which Sandhya sits every time and tries to clarify so many things for the surgeons and the oncologists.
So next, shall we just move on? Bhavna, the next picture.
Yeah. So the take-home points, can I summarize?
Yeah, just
So one is we started that this is a reverse presentation. So you cannot think that 77-year-old will not have a cancer. Okay. Older ladies also, usually, they say 50s to 60s is the maximum. Most of the cancers are there. But okay. And then you have to do a mammogram. Though she's 77, mammogram is the ideal investigation of choice. And only it's not essential that a hard mass would be a cancer, or a soft mass cannot be a cancer. Okay, it could be either way. Then third is when you have when the patient tries and tells that you do a BCS for me, breast conservative surgery, you need to do an investigation, further investigation, either MRI or a contrast enhanced mammogram, to see if there is any other lesion in the same breast or in the opposite breast. And then depending upon how whether there is one lesion, two lesions, or both breasts have a lesion, you have to do biopsy and pathology for histopathology and IHC for all the lesions, and then decide the treatment accordingly.
One point here that IHCs can be done in core biopsies. Most of the time, they are a reflection for the main tumor mass. And sometimes, occasionally, if we see a single file, we also add E-cadherin to rule out a lobular carcinoma of the breast. Sometimes, many times, you see them cells are streaming and they look like lobular. So we add E-cadherin, but otherwise, the regular breast panel is ER, PR, HER2/neu, KI. And then, of course, EGFR and AR also we add as a breast panel. So all that can be done in core biopsies, and we get beautiful cores from Bhavna. So we do the entire thing on core itself. Yes. So shall we move on to the next scenario, Bhavna? Oh, any questions, by the way? If anybody has any questions in the first case, second case, before we move on to the next few cases.
You can go to the next case.
Yeah, okay. So this was a scenario 3, lady with a lesion that needs caution, and we really struggle with it sometimes. So this is a 46-year-old lady with a history of spontaneous serous nipple discharge. No family history, no prior imaging has been done. And then, yes, Bhavna? Ramya, when you see suspicious nipple discharge, what would you think? And do you do a nipple fluid cytology? And what is the course of action?
Okay, right. Thank you for that. So this is a 46-year-old lady with a serous nipple discharge. Okay, so when you look at anybody with a history of nipple discharge, the questions that we ask would be the questions that we ask, look at whether it's a spontaneous nipple discharge or it is elicited. Sometimes sometimes you find that people, as they're having a bath, when they're lathering soap, sometimes few drops of serous fluid may come out. So it should be spontaneous, staining their underclothes when they get up in the morning or during the daytime. A spontaneous nipple discharge, which is unilateral, seen only on one side. And even when it's seen on one side, it's coming from one opening all the time and not multiple openings. So, and if it is, of course, everybody gets awakened when you have a bloody nipple discharge. But the point of caution is a serous nipple discharge can also indicate an underlying malignancy. So these are the points. Blood stain discharge from the breast during postnatal period. Again, it could be something that the patient may be having an intraductal papilloma, or there is a intraductal insipation secretions, and sometimes it could be blood tinged. But always a blood tinge should give us the red flag that maybe we are dealing with either intraductal papilloma or is it a malignancy. So single duct, unilateral breast, spontaneous with a color which is bloody, definitely I'll be worried. But serous nipple discharge, unilateral, cannot be ignored. And currently, I used to, maybe 20 years back, send the nipple fluid for cytology. But what the pathologists usually see is some macrophages, some deformated epithelial cells or ductal cells.
May not be a
with
reflection.
nothing. Yeah. So basically, the patient thinks you're going to come with a brilliant diagnosis at the end of a simple test like nipple fluid cytology. They pay for it. And at the end of it, the pathologist can see only what they can see, and therefore I have to do something else. So we have stopped doing nipple fluid cytology. Instead, Bhavna will help us with the imaging. If we see any lesion inside the duct, then she's going to help us do some pathological specimen.
Yes.
Yeah, Bhavna.
I think we'll have to, yes. Bhavna.
So imaging, what would you choose is sometimes, when we see since she's 46, so again, she goes in for X-ray for sure. Okay. And as we know that we are going to do ultrasound also, sometimes if the history comes to me before, they start taking the mammogram, if it's a nipple discharge, I would like to do ultrasound first, because what happens is when they compress the breast on mammogram, sometimes the fluid comes out. And if there is a papilloma around the fluid, I won't be able to see it clearly. But anyway, the bottom line is X-ray has to be done because she's 46. So X-ray was done, and then it showed a small mass, but ultrasound is more classical in this lady had a papilloma. On ultrasound also, we thought it's a papilloma. You can see there's a mass and there is a beautiful internal that, vascular core is there. You can see, okay, feeding vessel, which we, if suppose this was not there, we would have thought of it as a benign fibroadenoma or something. But since this has a beautiful vascular stalk inside, which is the sign of papilloma in ultrasound. So we also gave a possibility of papilloma. Plus, she was, symptoms were serous nipple discharge.
Any other imaging tool? I mean, here you made it out in
yeah. So what happens is, anyways, her mammogram has been done, but now since the papillomas are sometimes they are so small, okay, and sometimes they can be central and multiple papillomas. So what we do is we just offer the patient, and we also discuss with the clinician that if we could do a MRI of the patient. So we did MRI, and you can see there is a mass here, near the nipple. You can see it in all the sections here. And these are called time kinetic curves, which showed us that it is a benign mass. This is what it is showing us, a rising curve. Okay. Right. And there were no other masses. So this was a solitary papilloma. And we could actually on radiology, though the final verdict will come from pathology, but we could on radiology quite confidently say that it is a benign papillary lesion.
So let's,
Intrapapillary.
we agree with you, Bhavna. Can you show the next pictures?
Yeah.
Core versus vacuum assisted. Yes, I think you just touched upon it. Bhavna, what would you prefer? A core biopsy in this case or a vacuum assisted?
This is a very hot burning topic and I should not answer this. I think surgeon should answer it.
Yes. Ramya, what do you feel?
Okay, we have to go be with times. So I gave up my direct core biopsy. I gave up my FNAC and then we went to ultrasound guided core biopsy. But the current the technology that is available is a vacuum assisted biopsy. The advantage is you may be able to remove the entire lesion and the treatment is over at the same time. And it is going to give enough tissue for the pathologist to comment upon. But the only small hitch is if this turns out to be a malignancy or a DCIS, in a vacuum assisted biopsy, the whole tissue gets pulverized. So we don't know whether the margin, the status of the removed lump will not be able to assess. So I have a little bit reservation. So I would like to do a core biopsy only. And if the core biopsy comes benign, then definitely a vacuum assisted excision, I would readily give the case to Dr. Bhavna, because what is best for the patient we should look at and not the ego of the surgeon. Thank you.
So so what we did is we did a core biopsy. You can see the needle within the lesion because we wanted to 100% be sure that, you know, it is a benign lesion. So we did a core biopsy and it came as a benign papilloma on histology. And then obviously madam gave the patient to me and we did a vacuum assisted thing. And you can, I hope if this video occurs, so this is not happening.
Okay,
so, okay,
can you explain it?
So what happens is we just place the needle. This is a vacuum needle, which we place under the lesion, totally under the lesion, and slowly, you know, the needle, with the help of the vacuum is created and there is a cutter which cuts the lesion and totally the lesion can be out. And, you know, the total lesion can be given to the pathologist, which was done by us.
Yeah, so as Ramya mentioned, usually it may come pulverized, but there are some areas which are pretty good here. And Bhavna just point out to that outer, that's the dilated duct. And inside you can see these finger-like, where the arrow is pointing, you can see these finger-like papillary structures. They all seem to have a fibrovascular, nice core. She showed some black and white pictures. I'm showing you the color pictures of the core. And they're all lined by, you know, the cells look benign, quite contained within the duct. But papillary lesions can be quite challenging for us because sometimes they're not as beautiful as this picture. Sometimes they are strewn all over and you're not sure whether you're dealing with an intraductal papilloma or a papillary carcinoma. So then we like to be again, if it's like this, we can call it intraductal papilloma. It's a little more disturbing, then we'll have to say papillary neoplasm, which can range from papilloma, benign papilloma to malignant papillary carcinomas, right? But then we have one, what should I say, Brahmastra with us. And that is in the next picture. Yes, Bhavna, can you just show us that? Yeah, so this is the P63 that we use. And I know it sometimes annoys the surgeons and oncologists and gynecologists, but this really helps us. You know, we want to be sure every patient has a right to right diagnosis. And so we should be using, when you all use so much of imaging, please allow us to use some IHC, right? So as you can see, there is a nice, completely that myoepithelial cells have taken up the beautiful brown staining, which means that these ducts have myoepithelial cells and they are not invasive. And so it is indeed a intraductal benign intraductal papilloma. So it's kind of confirming what was already said. So I think I rest my case. This is an intraductal papilloma, benign. Okay. So any take home points? Yes. So Bhavna, any one point? We have 2 more cases to go and we don't want to
So take home point is that now we have a latest treatment, which is called vacuum assisted excision, which we can do it for papillomas, but it cannot be done for all papillomas. If they're very close to the nipple, we usually don't do it because, you know, then you can suck the nipple inside. So we have to assess the patient prior to that, you know, is it a suitable case or no?
I think I saw one question there that whether hyperplasias can give bloody nipple discharge. Ramya, you want to answer that?
Yeah, maybe it is a possibility, but it should be a self-limiting, or after some time, after the lactation period, it should settle down. That's what I think mom was trying to say. It is possible. You have to keep a close watch on this patient. If it's persistent, then again an imaging and some other intervention has to be done. I answered 2 other questions in the Q&A myself, so it's answered. Thank you. Do we have time to go to the next case?
Do we have 2 more cases? If you have time, we'll take
Dr.
one.
Dana?
You can quickly.
Quickly we'll go across.
Yeah, we'll quickly go across. Yes, Bhavna, next. So this is a growing concern in a pregnant woman, very apt for this session. 29-year-old primary, second trimester.
Not really. This is the Chennai Menopause Society, okay?
Okay. I got it wrong.
But anyway, this is something that
So that is for Sunday. That is for Sunday.
So by the time
sorry. Okay.
So no nipple discharge, no nipple retraction. Family history of breast cancer is positive. Next slide, Bhavna. Yes, Ramya, you had some diagnosis in your mind when you looked at this patient.
Yeah, basically because she's young and she's pregnant and she's got a large lump 4 into 5 centimeter in the upper outer quadrant. Again, this seemed to move with the breast tissue, but again, in pregnancy, the breast can be, it can be engorged, it will be increasing in size. There's hypertrophy of tissue. So it's a little difficult to really comment, but there was an associated axillary lymph node, which was 2 centimeter in size. So I would term more in favor of a suspicious mass, and especially if the patient is not aware of this lump prior to the pregnancy, then I would be really worried about this mass in this lady.
Okay. Radiology, Bhavna. A quick look at radiology.
So since she's 29, and she's pregnant, she's second semester. So we will go ahead and do her ultrasound first. Okay. So ultrasound of both breasts was done. And unfortunately, what we could see is that there is a mass which does not have very defined borders. Okay, it has hazy borders, you can see, and there are some calcifications which are suspicious calcifications, very tiny calcifications. So, and when we examined her axilla, also showed a lymph node with suspicious cortical thickening. It was more. So we put this as a suspicious mass. So when this happens, now the main question comes is that whether you can do an X-ray or no. Okay, or you can do an MRI of the patient or no. 2 things the surgeons will ask us. So we can actually not do in second and third trimester. It is difficult to do MRI because you can see that the patient has to lie down prone. But if the first trimester lady is there, we can do MRI, and MRI of the breast has to be done with contrast, and it is proved that it will not. The dose is so small that it will not affect the fetal. It will not cause any fetal abnormalities. And secondly, whether if you can do, like in this case, okay, if I want to do X-ray and I did X-ray, because the dose which will reach the fetus is harmless. Okay, it is within the permissible dose, and we can cover that area with the lead apron, and we can go ahead and do only one breast X-ray because we know that there is nothing in the left. So we did it, and you can see very clearly that there's a big mass here with lot of small suspicious calcifications, sand-like calcifications, borders are hazy, and you can also see that axilla has a big lymph node. So putting these 2 together, we gave it as Biroids 5. That is directly we gave it as a highly suspicious of malignancy. So next is we did a biopsy. Okay, and this is the biopsy results.
So
Sandhya has to tell us about the role of FNA versus core.
In a pregnant woman. Yes.
A lot of people, again, the family will say, why you want to put a big needle? Can you do FNAC and be done with it? So FNAC should not be done. Maybe you can tell now why.
Yeah, that's because in a pregnant lady, these cells will already have the effect of estrogen. So it's very difficult sometimes to differentiate between the changes related to pregnancy or it's because of the mass. So generally, we would prefer in a pregnant lady, a core biopsy definitely. And as in the left side, you can even see the invasive islands, and we can also do the immunohistochemistry and determine what molecular subtype. So FNAC, I would take it with a pinch of salt. In a pregnant lady, it's difficult because it's difficult to differentiate. And this was the final specimen that came, grade 3 invasive mammary carcinoma. You can see this very aggressive looking, angry looking cells, a lot of mitosis, and this was an infiltrating mammary carcinoma. Next slide. I think we did the molecular subtyping also. Yeah, as you can see, ER is strongly positive. PR is negative, HER2 neu again is positive, and Ki is more than 20%. So this was a luminal B HER2 type, subtype of HER2 positive subtype of breast carcinoma. So I think all this can be done on a core itself. So that's one advantage that the core offers. So yes, Ramya, anything after that? How would you go about this case? Yes. So would you want to give chemotherapy?
So again, the thing, she's in second trimester, if I'm right.
Yes.
So the options, you can go and do upfront surgery in the second trimester. There is no problem at all. But the problem comes when you offer a BCS, if at all you're offering, because she's very young. If you do a breast conservative surgery, remember what Dr. Selvi said, it has to be immediately followed with radiotherapy. Otherwise, the chance of recurrence is very, very high. And this is not the correct treatment to offer. So if you're going to do a breast conservative surgery, this is kind of out, not for this lady. We have to offer surgery upfront as modified radical mastectomy, which is a very devastating decision to be taken for this young lady who's, expecting a very happy occasion in the family. So it needs a lot of counseling. And I think all obstetricians, gynecologists, it is a real struggle to sit and convince them to undergo this. But I don't think general anesthesia in the second trimester is going to harm the baby. Baby is going to be safe, but the lady has to be convinced that she may have to undergo MRM. Or the other option is you can give a neoadjuvant chemotherapy with selected drugs, which are safe for the mother and the baby, and wait till term she delivers, then you can do subsequent surgery. So both options are there. Again, a multidisciplinary tumor board, but whatever the board decides, the family and the obstetrician has to sit together and decide. It's a very, very, the difficult decision to make, but whatever is best, we have to offer, and they either take it or leave it. So we have done it sitting with a gynecologist, obstetrician across very difficult decisions we have made. But the thing is, you should remember BCS, though she's young, you can offer BCS, but we cannot give radiotherapy during pregnancy. So that ties our hand up, and we'll end up doing a modified radical mastectomy with all the adjuvant treatment that is usually given after the delivery. So you can give chemotherapy, selected drugs. You cannot give radiotherapy, and hormonal therapy also better you start only after the delivery of the baby. Again, the obstetrician will tell us best, and the medical oncologist, which one is secreted in the milk across, whether the mother can breastfeed the child or not. So there are so many issues in it. So we'll, I think, sum it up like this.
Yes, next, Bhavna. So I think we have summed up the points here. Shall we go on to the last case? Quickly run through.
I think Madam, tell me.
Yes, or we'll just go back to the last slide and say a happy.
No, you can go through the slides. If you have slides, you can go through.
Okay. So next one, this was, I think, interesting. A distressed damsel with breast mass, 24-year-old young lady. That's interesting. With a history of lump in the right breast, and she's super anxious because they all immediately Google about the breast lump, no family history. And when Ramya examined her, I think, Ramya, you found a freely mobile lump in the lower inner quadrant.
Yeah,
right?
that's right. So, and no axillary node. So I would think of obviously a benign lump, and in this age group also.
Yeah. Yes. Next. Yes. So clinical diagnosis was a fibroadenoma. Okay, fine. And yes, Bhavna, a few points about imaging for fibroadenoma.
She's a young girl, so we'll just go ahead and do ultrasound. There is no need of doing mammogram unless on ultrasound you feel something is suspicious. So now, Sandhya ji, would you like to?
Sandhya ji, I would always, Bhavna ji, I would say FNA is good enough. Don't take away the FNA from us. This is a nice case for FNA. It's a nice, well circumscribed. You also think it's a fibroadenoma, and we also feel it's a fibroadenoma. So let's have the FNA, and then if you feel that there is something wrong, then we can do a code, right? Yeah, so the FNA was done, and as you can see, there's a classical, just point out to the staghorn pattern, Bhavna, if you can. Yeah, it is called the classical staghorn pattern. The cells are all very cohesive. They are not moving away from the main mass. So this is a very classical FNA appearance of a fibroadenoma. So it's a straight, we'll just say, features are that of a fibroadenoma. And of course, you still went ahead and did a core. So anyway, thank you for that. So we confirm that it is indeed a fibroadenoma, and this is the core biopsy. Yeah, now the management. Yes, Ramya, if you can just.
What was the size? I forgot the size.
It's
Size
a
was around 2 into 3 or something, I think.
small size, actually.
Small size, yeah, 2 into 3.
Yeah, right. Okay, so it could be a wait and watch. Again, remember this is histopathologically, it's still a fibroadenoma. So you can wait and watch, tell them to come for 6 monthly short-term follow-up with an ultrasound of the breast and a clinical examination. But many of them know they're all Google Docs, super anxious. They can just relate to the word tumor. They are not, they get worked up. So if they want it to be removed, then again, we have two options. The conventional age-old like us is a surgical excision under general anesthesia, or we have the magic hand of Bhavna. Then she can do a vacuum-assisted excision, which is scarless, literally under local anesthesia, doesn't need admission. It's an outpatient procedure. And again, what is best for a young girl, we should be able to offer that.
I think Bhavna did a vacuum assisted excision. Yes, Bhavna, quickly, if you can just show us
just showing a
magic.
video that the needle is placed under this fibroadenoma and how it sucks. Luckily this video is working, so you can see that it will just suck the lesion. Just give me a few seconds. The needle will come and it will suck.
Yeah.
We are starting. Sound will come. This is not talking to the patient, so it has come like that.
Yeah, you are talking to the patient. I thought you were
So
telling
now it has started. See, it has started sucking, and it just keeps coming into the chamber, which you have. See,
Yeah.
it just keeps cutting and bringing the lesion out. So finally, end of the procedure is very satisfying to see that there is nothing left.
Yeah.
This was around less than 2 centimeter fibroadenoma, so it took us about total procedure time. The sucking time was about 7 to 8 minutes. See, you can see at the end of the procedure, it's just gone. Last thing.
The macrophages will come and clean up the rest of the areas, actually.
So it's done. So we are done. This is the last cut which we have taken. It's a simple thing. It takes out the entire lesion.
Okay. Chalo, next slide. Yeah, so it
This is
comes
how
like this to a sad.
This is how it does not come as a, a lot of patients think it will be a ball. They tell me, you show us where it is. It's all come into, it's morcellized. So the tissue will be like this. And later on, you can get some small hematoma, which gets, sucked by itself within a week time and all. And this is this is the scar to the breast tissue. Like basically there's nothing. It's just that needle injection. That's all.
Okay, Bhavna. Yes. So this is finally, yes, it is fibroadenoma, but it came in small bits. Yeah, it was like cut vegetables you get, no? Like that. So it came diced. But anyway, there are still fragments which tell you that it is indeed fibroadenoma. So the thing is
The question for you, Bhavna, from ma'am. Whether there will be spillage of malignant cells if by chance we miss.
Yes, very important question. Bhavna, bolo.
Madam, there is what is happening is now our oncosurgeons, if the lesion is less than 1 centimeter, they are telling me to wrap the lesion because there is the possibility is that we will take out the entire lesion and pathologist will give us a the best result, whatever they can do when, we don't miss it with core. So what happens is we should understand when we are expecting a malignancy, we have to go inside and do the margin clearance. So what we do is even when we are taking out the entire lesion, we put a clip inside. And usually there is no spillage. Actually, there is no such thing which I have seen because we are doing it very contained thing. And here, one more important thing is when we are doing a core biopsy, if we take 3 or 5 cores, we have to go again and again. Here, we don't insert the needle again and again. It's only one insertion. So there is actually less chances.
And if it's malignant, I think there is a follow-up surgery or whatever. That will take care of.
They have to go and clear the margins. They have to go with the help of that clip, 100%.
There's a question for you, Bhavna. Any contraindication to VAB assisted excision?
Yeah, any contraindication? I can tell you some.
As I told,
contraindication,
as I told that, when it is stuck to the pectoralis muscle, okay, or very close to we have done few cases which we can make a space by injecting a saline between the pec and the lesion so that we can raise the lesion. Or if it is very close to the nipple, then it should not, or very close to the skin, we should not, suck the skin inside.
There's no bleeding or anything, Bhavna. It's a kind of.
There is minimal bleeding as I showed you. But we usually see main thing what we are doing here is the suction is done very fast. But after the suction, I have to give 10 minutes compression with cold pack. That is the most important thing. So the patients, with God's grace, whatever patients we have done till now, there is in our
Nothing.
experience, nothing has happened. Yeah.
Okay, I think we'll move to the last slide. So take home, we showed 5 scenarios: mid-adult lady with rapidly growing breast mass, that was phyllodes, benign phyllodes; postmenopausal lady with a painless breast lump; premenopausal, that was malignancy; then premenopausal lady with a nipple discharge, which turned out to be a intraductal papilloma; pregnant lady with a growing breast mass, again it was malignant; and a young anxious lady, a girl with a breast mass whom Bhavna did a vacuum assisted excision and that VAP, and that came out. So I think different scenarios, and I think we are here ready to answer any more questions. And I think, thank you so much, Dr. Dhana, for inviting all the 3 of us. I think we love to do these sessions. We've been in different places and we've come offline, online. And I really thank the audience. You know, they've always shown so much interest in wanting to know all the 3 aspects. So, yes, any parting words? Yes, I think last slide, Vikadu.
Only
Last
thanks
slide,
to,
the last slide. No?
thanks again on behalf of all 3 of us to the Chennai Menopause Society and Lakshmi and all the office bearers for giving us an opportunity to address these issues in women. And thank you so much. We really enjoyed the session. Thank you.
And
we really were looking forward to this. This was
Madam,
as a highlight.
1 minute. I want to say that, you know, please, all of us only, doctors only, we are not doing screening mammogram. So I'm holding hands and telling you,
She's
please.
indicating us also.
Mammogram. Please.
We are also included in the list.
Yeah.
Okay.
Yeah, very rightly said. We as doctors, we are very least care of ourselves. So
Exactly, madam.
I would
Exactly.
also
You can say that.
I would also like to say that please do follow.
Yes.
We are always advising our patients, but not following that. Thanks a lot for inviting me over here, and I enjoyed the whole session. It was really very, very nice and very informative.
Thank you so much. Thank you for your kind words.
Thank you.
Thanks.
Thank you, Dr. Shanti and the whole team.
Yeah. Thanks a lot to the trio for the excellent interaction, which has brought out a lot of practical points. And you have been very clear in your take-home messages. Thanks once again. Sahiti, can you post our questions? We had questions. We wanted our delegates also to interact. So the first one was, what is the role of screening mammogram? Finding mass before it reaches 1.5 centimeters. That was the correct answer. And the second one, when will you refer average risk patient to screening mammogram? The answer was 40 years. And I have great pleasure in congratulating for the first person to get the correct answers correct. What Usha V from Chennai. Congratulations. And the second person was Dr. Kokila Chenian from Krishnagiri. So this is really reaching whole of Tamil Nadu, and many have got it correct. The questions were quite simple and they have been very attentive. And I'm really happy that many have answered. These 2 were trigger happy. So we congratulate both of them. And now coming to vote of thanks. Yeah.
Good evening, everyone.
Yeah.
Good evening, everyone. I would like to thank Shanti ma'am and Meera ma'am for giving me this opportunity. It has been an honor to be a part of this wonderful Chennai Menopause Committee. On behalf of CMS, I would like to extend my heartfelt gratitude to our esteemed Chief Gift, Dr. Anita Shah, Vice President IMS, and guest of honor, Dr. Jayashree Srinivasan, past President Oxy, and our esteemed chairpersons and our speakers and our esteemed speakers for enlightening us with their talk on breast and menopause. Thank you, everyone.
It was really, all the speakers were excellent, and the tripartite dialogue was, of course, as usual, excellent. So I thank all the 5 faculty members who have really given us messages, and the three which were, we were happy to have the chief guest of honor, and the three chairpersons too. It was really a wonderful evening. So thank you once again. And I should thank Dana for being the MC. Thank you very much. And my dynamic secretary also, I should thank Meera, so it was really team effort which has brought about this. Thanks a lot.
See
Thank you,
Ramya and Bhavna on Sunday again.
Yeah. And Sagiti, I should thank a great deal. And we should thank Chitrakala of Shield for that medal. We keep on pestering small corrections. I keep on making. So I am very thankful to Shield for having given us a wonderful platform. Sagiti for having conducted the program well without glitches. And Chitrakala who really obliges us a great deal. So thanks once
Thank you so much.
Thank you so much, ma'am. And
Thank you.
Shall we take
yes,
on the camera? I think the faculty can have a photo.
Yeah, Ramya, Bhavna, Sandhya, Selvi, Dr. Selvi, Bhavna. Yeah, please take a pic.
Okay, whoever, Rajalakshmi, please
switch on the video. Madam, you can take a picture, madam. Yeah. Selvi, madam. ஒரே நிமிஷம் போடுங்க மேடம். Somebody should be there. Selvi. Somebody, Selvi. Dr. Selvi.
She's not there.
Okay, you take a picture.
Yes, ma'am. Take some pics, ma'am.
Thank you so much.
Very much.
Thank you very much, and thank you once again the trio. Thanks for obliging.
Thank you.
Yeah, it was a pleasure having you at great demand to bring all three together. Okay, thank you so much. And